So Rachel's going to start with the 19s.
I still like to pinch to go in. Some people like to make it taut and twist. I still feel like that. And I've got it halfway under the skin. I felt kind of that pop for it to start. And then I'm going to go ahead and start threading it. And again, I'm just pinching the skin and kind of pushing it over the cannula. I've still got my thumb back here on the thread just in case I would have to reposition. Here, as you're coming off that zygoma, it wants to come superficial, so make sure you're staying. You may have to adjust your angle up just a little bit to keep it deep. Here, I am gently applying some pressure as I start to twist the thread to deploy it. Here, I'm going to go ahead and use the hemostat.
And if you really pay attention, she's not pulling on the thread. She's holding tension, but she's getting this nice little pouch here and pushing down on it, whether it's with your fingers or with retracting the thread the other way.
I find that coming in behind the thread helps get the next one in. Sometimes it's on top of, but still trying to come in at that 90 degree till you feel it pop under the skin. A lot of this is a sensory, like you really need to pay attention to how it feels when you're deploying these. It's something that sometimes can't always be taught.
And if you have really pretty well virgin tissue, it's pretty smooth usually. If they've had other products in there, whether it be Sculpture, Radiesse, other things, sometimes it feels a little catchy, but if you can feel your tip of your cannula, you know where your cannula is, you're pretty safe to move through. But if it feels like the tissue's gripping the cannula, you're probably in a muscle and shouldn't be there.
So here, she's very narrow in her anatomy. Her tissue layer is thin. So I really want to make sure here that I'm going to get enough of the thread deep enough that we're not going to be able to see it bulge.
Exactly. And you can see with how there's no indentation of the skin that she is not superficial at all. How can you tell if you're superficial? The skin will literally dip down in that area if you're too superficial.
Cool.
Mm-hmm. And when she's getting a little bit of tension as she's going through, if she knows she's in the right plane, what you're going through is some retaining ligaments. And the patient will actually feel a little pop.
Now I'm going to go ahead and tighten these and cut them so then I can put the lock in. It makes it a little easier. So again, I'm pulling up gentle pressure as I'm kind of pushing the skin down so I can cut the threads. There are just two here, but you still want to go ahead and twist the threads so that they can kind of lock onto each other a little bit. So here I'm pulling a little bit of tension and traction. I'm going to give it a little bit of a twist motion to get it under the skin. Once half of it's under, we're going to go ahead and start feeding it up, and it's a pinch together and push There we go. Once I hit resistance, I'm done. Pinch together, push down, was in. Hit resistance, I'm done.
This is our molded max. As you can see, the molded max has a little stopper at the end, which allows you to not have to hold the thread if you want to redirect. The cannula is a little different also. It's a W, so it's a little, I don't want to call it sharper, but it's got a little more ease through the tissue, and there's no folded over thread. So when you insert this, you put it all the way in, you got to pull out 1/4 of an inch. We're going to loosen this, pull it out. As we pull out that 1/4 of an inch, then we got to tap the thread in. You have to make sure as you're tapping, you can feel that thread engage. Then you can pull the cannula out. So,
okay, we have the cannula again. These are the molded max. We can loosen the holder for the thread instead of keeping our thumb to have to hold the thread. This little plastic piece does that for us, but you may want to just give it one little jiggle before you go to make sure it's loose enough. You can see the thread does not come out the end of the cannula. We're going to go in our track that's already numb. I just came and pulled the thread out of the way so I could get back in here. I'm in the right plane. Come across. I'm as far as I want to go. I'm going to pull the plastic piece out. I'm going to give the thread, kind of push it almost like you're threading the needle, or you can do the tap tap, and it's staying in here. So I'm going to go ahead and remove my cannula, and then we can go ahead and pull this side to tighten. I'm just going right under the jawline. I'm not really meeting anything strong and resistant. I'm stopping when we get as lateral to our line. Again, I'm going to remove this plastic piece. I call it threading the cannula or tapping the thread in. It's going to start to disappear. That tells me it's anchored. And there we go. Then we can pull to get our tightening. This is our last one. Again, we're not forcing anything. We're just letting it glide. The tissue plane and back at our line. I'm on taking the plastic piece out. I'm going to thread the needle or tap, tap, tap and deploy.
PDO Max, elevating the science of beauty.